patient has. Renal failure, what opioids would be safe, what opioids wouldn't be safe. Hepatic dysfunction, involvement of the liver, what would be the right opioid to choose. In a hypothyroid patient, how and which opioid would I be using? What do I do in somebody having morbid obesity? So the comorbidities of the patient will also influence the right choice of the opioid. Side effects of the opioids differ from opioids to opioids. There are some side effects like post-operative nausea, vomiting, which are seen at a higher incidence with some of the opioids. Again, to give an example, when you use tramadol, we see that patients who receive tramadol have a higher intensity of post-operative nausea, vomiting. So it's an expected side effect. Now, if you have a patient with a high risk of post-operative nausea, vomiting, as assessed by your APFEL scoring or pre-operative assessment, then it wouldn't make sense to use opioids which would cause higher post-operative nausea, vomiting. So if you know the side effect profile of the different opioids, you can make a right choice which would reduce the intensity of side effects in the post-operative period. Availability, having said everything, if I don't have that drug, there's nothing that I can do about it. Remifentanil may be my first choice for this particular surgery, for this particular patient, and for whatever indication. But when it is not available, obviously I have to go for my second choice. So there are several opioids which are not available freely in the private practice, where acquiring the opioid because of the legal restrictions would be difficult. So there wouldn't be availability of opioids at all. Fentanyl might not be available, morphine might not be available. So in those situations, among the available opioids, you have to make the right choice. The monitoring facilities in your post-operative ward will also influence this decision, because if there's nobody to look after the patient, if there's no good standard AHA monitor, you can't just give a strong opioid which can cause a respiratory depression and leave the patient in the post-operative period. So your choice of opioid also will depend on the monitoring facilities. How do the comorbidities influence? Let's see a little detail. Liver disease. Liver disease in the perioperative patients, till it's an end-stage liver disease patient who is coming for liver transplant, usually the opioid metabolism is not affected to a significant level. The reason is most of these opioids have a very high hepatic extraction ratio. As soon as they come into the liver, they are extracted, by the liver just like anything. 80%, 70%, 90% of them is extracted, and then with whatever little reserve of liver